Thank you very much, and thank you all for staying for this session. I appreciate your interest and presence here because it's a really interesting area to get your head around. So I wanted to talk about healthcare and people with intellectual disability and people with autism as well. As Harry said, our centre is funded by the Department of Health and Human Services to try to improve the health outcomes for adults with intellectual and associated developmental disabilities in our state. And we do that through a range of educational, research and clinical initiatives. We're a statewide service with a very small staff, so our clinical service is quite small, but we have a telephone advice line so that we're very happy to discuss any of your patients with you by phone, as well as doing assessments if that's what you need. I wanted really to summarise what I want to say to you this afternoon in 5 key messages. First, talking about health disparities and inequities experienced by this group, because people with intellectual and associated developmental disabilities have poor health outcomes for a whole range of reasons, and so there's a need to focus on the healthcare of this particular group. And all of you in general practice would have patients with intellectual disability in your practice. Often they may not be identified, but when you start looking, you will find. A very important part of the care of people with intellectual and developmental disabilities is establishing an etiology, because that informs our health care, and I'll come back to that. Disabilities coexist. It's not fair. Disabilities aren't shared out equally amongst us all. If people have one disability, they're more than likely to have more than one. The 4th point I want to make is a change in behaviour is a communication. And 5thly, that there are tools and resources to improve your health care and to support you in the care of your patients. So first of all, people with intellectual disability are a group who have multiple chronic and complex medical issues. Unfortunately, many of these go unrecognised and undiagnosed because of the communication impairments that come along with developmental disabilities. People are often on multiple medications and sometimes inappropriate medications, and very often they're not able to let you know about the side effects or adverse effects of those medications. So being vigilant about the ways in which side effects might demonstrate themselves is an important part of our responsibility. They have fewer financial resources. They have less access to health promotion and disease prevention activities. They often are quite socially isolated, and they have a lesser problem-solving ability because of their cognitive impairment, and so can struggle in the lives and life decisions that they need to make. So all this means that people have a higher morbidity, live with a greater burden of disease, which impacts, of course, on quality of life, with chronic ill health decreasing both function and independence and physical, social, community education and employment. And it also leads to a higher rate of premature death. People with severe disability die some 20 years earlier than the general population. Many of the causes of death are preventable. Well, we're all going to die, 100% of our patients will die, but the premature death rate amongst people with intellectual disability is higher than their aged peers because symptoms are not recognised and appropriate investigations and referrals are not done. So we really do need to focus on the healthcare and offer proactive healthcare to this vulnerable group. It's always helped me to think of developmental disabilities and the impairments resulting from them as a grid. So you can have a cognitive impairment, intellectual disability, you can have a motor impairment, You can have a sensory impairment. I'm backwards to you. Sensory impairment, their vision and hearing impairments, or you could have a social impairment, and that's the autism spectrum disorders. And it's more common than not that these coexist. So one of the really important things that we need to do in our clinical practice with this group of people is to look for the coexisting impairments, the coexisting disabilities, and in particular, always look for vision and hearing impairment with regular assessments. If people are battling to understand the world in which they're living in and to engage in that world because of their cognitive and social and physical impairments, then an added sensory impairment makes that job just that much harder, and that can often be something we can do something about. So when we think about developmental disabilities, there's a whole lot of terms that we use, and once again, I think it's helpful to divide them into the terms that reflect the etiologic diagnosis and the terms that reflect the functional diagnosis. So a functional diagnosis of cerebral palsy, intellectual disability, autism spectrum disorders tell you about the function that's affected. So knowing somebody has cerebral palsy just tells you there's something wrong with their motor system. Their muscles don't work as well as they should. Similarly, autism spectrum disorders, people have trouble processing social information and hang on to routines and predictability in their life. It doesn't tell you, though, anything about what's caused those conditions. On the other hand, the etiologic diagnoses lets you know the cause, so that this young man has Fragile X syndrome. So we know the cause of his disability, and from that knowledge comes a whole lot of actions around medical surveillance, around family and genetic counselling, and around prognosis and care. So separating those in your mind is helpful. In terms of intellectual disability, we're talking about a lot of people. We're talking about in Victoria 1.5 MCGs full of people have an intellectual disability. And the diagnosis is people having an IQ under the arbitrary cut-off point of 70, which is 2 standard deviations below the norm, and also having coexisting difficulty with everyday tasks. For instance, learning, communication, self-care, self-organisation, the kinds of things that we all need to get through the day. And because we're talking about intellectual disability as a developmental disability, we're talking about a condition that begins in the developmental period before the age of 18. So obviously there's quite an overlap with ABI, and sometimes the decision about whether somebody is identified as having an intellectual disability or having an ABI depends on service-related access issues. For instance, the TAC, if somebody has a brain injury from a car accident, it's much more useful to call yourself having an ABI and then having the compensation from that. So, what does intellectual disability mean for the person themselves? What it means is that people just learn and process information more slowly and have difficulty handling abstract concepts like time or money, or if you're asking about calcium intake, you might be asking somebody around their diet, and you're asking questions about yogurt and milk, and most of your patients will know that also means cheese, and they understand that you're talking about calcium input. For somebody else with an intellectual disability, they might not understand that conceptual underpinning of your questions. And interpersonal relationships, boy, they're complicated for all of us. The subtleties of how to behave where and what to wear at what time, and when you can speak and the way in which you speak to different people. And for people with cognitive impairments, that can be very difficult. And it can be particularly difficult around the teenage years when what's what's cool and what's not, what's appropriate and what's not, changes by the hour. So the support and assistance that people need really depends on their cognitive ability, of course, but it also depends on the expectations of them within particular environments and the presence or absence of other developmental disabilities. So this is a young woman called Jackie. Jackie has Down syndrome. This is her house, the supported accommodation that she lives in. She lives with 4 other young people with disabilities in that house, with a staff supporting them 24 hours a day. 1 sleepover staff member, a couple of staff members during the day. Jackie is very independent in that environment. She helps with the cooking of the meals, with the house cleaning, with the laundry. She travels on public transport back and forward to her workplace. She has friends, she has a social life. The staff provide and organise the transport for her to outings at night, but a lot of the time she's very independent because she has the support she needs in that environment. But put her in an environment where she's challenged with having to organise her opportunities, having to organise her relationships, having to organise her healthcare, and she doesn't do so well. The young man in the bottom picture, a young man called Chris, 24-year-old man with a severe intellectual disability and cerebral palsy and a visual impairment and severe epilepsy. So, yes, intellectual disability is one of his issues, but not the only one. The autism spectrum disorders are a group of disorders that are identified early in childhood. The DSM-5 has broadened it a little bit or blurred the margins a little bit. DSM-4 made it very clear that the symptoms had to be there by the age of 3, but in DSM-5 it's early childhood. And it's manifest through behaviours. So the 3 characteristic behaviours are that there's an impaired social interaction and communication, and the behaviours reflect the person's difficulty in understanding social behaviours and expectations. So if any of you come into this room, you can immediately pick up what's happening in the room. It's a lecture situation, and you immediately also know what's expected of you in that situation. You know, people who come in late tend to make themselves small and move to a chair very close to where they are and sit down quietly. So you know from reading this social situation and reading the facial expression and the body language of the people in this room what's expected of you. That's very difficult for people with autism spectrum disorders. And so many of their behavioural disturbances are around that lack of knowing how to behave in different situations. If you imagine that you find the social world in which you live very confusing, and you also find verbal information difficult to process, imagine how confusing the world would be. So no wonder that people hang on to predictability and sameness and routine and become very distressed if that's interrupted. And so you see people having very rigid patterns of behaviours during the day, very rigid routines during the day, and major tantrums and meltdowns if those are disrupted. People often will have a very restricted range of activities. So in children, young children in whom this diagnosis has been made, you'll see that they might play with cars, but if you say, how does he play with a car? Ask the next question, drill down. Well, what he does is turn them upside down and spin the wheels. Or he lines them all up across the room. Or he puts all the red ones together and just doesn't show any interest in the others at all. So it's not imaginative play with cars, it's using cars in this way of creating a sort of a boundaried world. And people with autism often manifest repetitive sort of behaviours and stereotypic movements. And then the third area is atypical sensory function. So sometimes people with autism are thought of, your children with autism are thought of as being deaf because they don't respond to their name. They can hear it, unless they're deaf, of course, but generally they can hear it, but they don't know that that sound has a social significance. They don't know that if you call out Jane, then I'm meant to look around. They don't know that social significance. And so it might be thought that the hearing's impaired. So that's one of the things we need to look at. But people with autism are often very sensitive to some stimuli. And for instance, people with Fragile X syndrome are often very sensitive to touch. So the fabrics that their clothes are made of, the labels on the back of the shirt. Or they might be very sensitive to noise, and so when the vitamizer's turned on or the vacuum's turned on, they freak out. Or they might be very sensitive to particular light. And so many of the behaviours are around either seeking a stimulus that they find very appealing, and sometimes that can be things like smell or taste, or aversion of a stimuli that they find painful or very unpleasant. A couple of quotes from a guy who had what sounded like quite severe autism in his early childhood years, did not have an intellectual disability, and developed an ability to reflect back on why he had behaved like he had at the time. And I find them quite helpful in understanding the behaviours of people with autism who are not able to express themselves in this way. This is a guy called Sean Barron, and he said, "I had no ability to express my feelings in words. The thought never crossed my mind that I could tell Mum I needed help. I had no idea that words could be used in that way. Language to me was simply an extension of my compulsions, a tool to use for my own repetitious behaviour." So he did lots of squeaking and squawking and in his early childhood years instead of speaking. He didn't speak till he was a teenager. He also said, "I loved repetition. Every time I turned on a light, I knew what would happen. When I flipped that switch, the light went on. It gave me a wonderful feeling of security because it was exactly the same each time. People bothered me. I didn't know what they were for or what they would do to me. I had no security with them at all." So, that gives us a little bit of insight into the kind of world that people with autism spectrum live in. Now, my third point is that etiology informs medical care. So there's a whole lot of causes of developmental disability. Anything that can affect the developing brain can cause a developmental disability. So that could be genetic, ischemic, infective, toxic, traumatic. And increasingly, of course, we're understanding more and more about the genetics, and so more and more of the developmental disabilities are being identified as having a genetic basis. And etiology is really, really important to identify. It's relevant to medical care, so that knowing, for instance, that Jackie, up there, the young woman with Down syndrome, has Down syndrome, informs us that we need to check her thyroid function on a regular basis. We need to check her vision and hearing on a regular basis. And when she's when she's a young adult at this age, she's got a particular risk of depression and anxiety, and later in her older years, she's going to be at very high risk of developing Alzheimer's dementia. So it informs our medical care. It also provides information about when and why the disability occurred, and that can be important for the young person themselves, and it's certainly important for the family, and can take away that sense of responsibility and guilt or shame or embarrassment or blame or all of those emotions that churn and bubble around in families when a diagnosis of disability is made. It also tells us about the recurrence risk for the person and the family, and obviously a condition like Fragile X syndrome, it's really important to make that diagnosis so that then other family members can understand the impact of that diagnosis, the relevance of that diagnosis, the implications of that diagnosis for themselves and for their reproductive future. It also facilitates an understanding of the behaviour a person exhibits, and for instance, people with Fragile X syndrome tend to have both an intellectual disability and behaviours that are autism-like or autism. And so knowing that they have Fragile X can help explain some of the behaviours, particularly around difficulty coping with change in the early years. And very importantly, it provides an opportunity for families and for people themselves to access all the information that's available to us on the World Wide Web. And there's an excellent organisation, the Fragile X Association, which provides information for families and for people with Fragile X themselves to learn about the condition. And we have a Fragile X booth in the exhibition centre downstairs. So the implication for that is when you are seeing your patient, if they have a developmental disability and they don't have a diagnosis, consider sending them off for genetic testing every 5 years or thereabouts, particularly if there's a family history or dysmorphic features. That's in your notes. Knowing that Jack has Fragile X helps to explain those different behaviours. I'll skip that. The next one is a change in behaviour is a form of communication. People who have trouble communicating may express themselves through their behaviour. We all express ourselves through behaviour. I can see out there in the audience who's interested, who's not, who's really hanging out to get home, who is having a little snooze. You know, your facial expression, your body language tells me a lot. And if you don't have speech to communicate, your behaviour might be the only way in which you can express how you're feeling and what your sensations are, both internally and externally. What's important is that when a behaviour change occurs and we're trying to understand why, we need to carefully consider physical and mental health issues and not just reach for our script pad. So don't respond to a crisis, to the demands to prescribe in a crisis. Instead, work in partnership with the person and their support structures, check physical and mental health, refer for a behavioural assessment, and review regularly. There's a medication spiral that's a real risk, that somebody behaves in a way that is a behaviour of concern and they get prescribed something, and then they behave in a way days, weeks, months later that upsets somebody again, and the dose is increased, and so the dose keeps getting increased and rarely decreased, and we see people on multiple very high doses of antipsychotic medication that's never done anything to help. So the point is that effective treatment depends on accurate diagnosis. We all need to be like Sherlock Holmes. Our job is to answer the question, what does it mean? So some tools to improve your healthcare of people with intellectual disability are, it's important to focus on proactive care, so working with disability support staff, investigating and treating presenting issues, of course, focusing on preventive care, anticipating medical issues, doing annual health assessments, and regular surveillance and monitoring response. This is in your notes and just goes through the training and background of disability support staff and the way in which you can work with them effectively. Medicare health assessment items are available for people with intellectual disabilities as they are with other vulnerable groups, and the item numbers are very familiar to you but can be considered for people with intellectual disability. The CHAP is the Comprehensive Health Assessment Profile, which is a guided history to take you through some of the presenting features that might suggest particular physical or mental health disorders, and it's filled out by carers. and brought to see you and laid out in a way that's pretty tick and flick through the pages and you can see where the problems arise. So a very useful tool. So the role of a GP, so it's about appropriate referral, it's about engaging supports and services, it's working in multidisciplinary teams, and it's providing information, support and advocacy as required. National Disability Insurance Scheme is a very important new structure that is going to improve the lives of people with disabilities enormously. And yes, there are a million teething issues, and yes, it's going to be clunky as it rolls out in Victoria over the next few years, but in perhaps 5 years' time, we're going to have a much better system than we've ever had before, and it's already improved the lives of thousands of people who have been through the system. For us, for doctors, what's important about the NDIS is that it focuses on function, not on diagnosis. So we need in our reports, our medical reports around our patients with disability, to focus on what function is affected by the disability, because it's the function that is going to drive the plan that is going to support people in their lives. Our centre has developed a new RACGP accredited ALM on the medical assessment and management of behaviours of concern in people with intellectual disability, and you'll find the details of that on your presentation in your app, and there's some more information. And there we come to the slides again, just summarising those main features about health disparities, disabilities coexisting, etiology informing medical care, and behaviour as a communication. Thank you for your attention.